is Lillian Pryor, and I am here with Mr. Rosheen McLaughlin and Dr. Yessayan. And we are just gonna have a nice little Q&A session and just chat about, first of all, Mr. Rosheen, your presentation was absolutely amazing. And then Dr. Yessayan is going to also just kind of give us, I guess, some updates in terms of AKI and when we're using CRRT for renal replacement therapy and the indications, how some of those indications are kind of the same as what we're used to and maybe a little bit different. He can kind of expound on that. So if you have any questions, I am monitoring and we have one coming in a minute. I'm getting ready to ask for Mr. Rosheen, and we'll get started. All right. So the first question just says a very amazing story. And can you repeat what contributed to your heart failure, Rosheen?
What contributed to my heart failure, basically when I was 17, it was a real virus. It's a difficult name to pronounce, but it normally affects African Americans in such a way that it's like a flu. But me catching it at an older age, it began to shut down my organs. What they informed me that it was like, they asked me if I was out of the country. They asked me if I was around some different type of birds. At this particular time in my life, I was working on the military base at the NCO club. And it might have been, the different troops coming in. But yes, the virus itself affected me, shut down my kidneys, my heart, and my lungs. But thank God, His grace allowed me to live.
Wow. Wow. Amazing. Okay. An amazing story. I'm just gonna stay with you for a minute, Rosheen. And so you've been on this journey and have experienced practically, I want to say, almost every modality, right? For
yes.
for renal replacement therapy. And just one of the questions I think that I had was just in terms of education, just from your experience, because we know we're seeing just with the executive order, we're trying to introduce patients to that home therapy and get more patients, kind of on that track. When do you think would have been a good time, or what's the best time for us to kind of start that education with our persons, who have chronic kidney disease? Is there a best time, or what do you think?
As soon as they are identified as individuals with kidney failure, and the possibility of going on dialysis, that will be the effective time to educate the patients. In other countries, as we know, they start patients at home first. Mm-hmm. And then when they do fail, that's when they go into the center. So for me, the best therapy for a patient to reclaim their life, to still feel the same in reference to energy, home therapy is the best treatment.
Right. Okay. Thank you.
You're
All
welcome.
right. And I have one question that's come up for Dr. Yessayan. We're going to switch gears a little bit. And just in reviewing and just speaking a little bit about your presentation and the renal replacement therapies consideration. How was COVID? Did COVID have any effect on the decisions, or was the COVID-19 diagnosis kind of included as an indication for that renal replacement therapy initiation? Have you noticed an increase in that?
Thank you for the question. So, so I live in Michigan, and we've been hit very hard last year with COVID-19, and I'm an ICU nephrologist, so I see the sickest of the patients. That's where I round. Now, in terms of indications for dialysis for acute kidney injury, they're the same indications as non-COVID patients. However, the truth is the incidence of AKI among patients with COVID-19 who end up in the hospital is very high. And it also depends on where the study is coming from and the hospital and the geographic area, of course. But what we've been seeing in many hospitals in the United States, at least, and also in many European countries, the incidence among hospitalized patients is 30 to 40% of the patients have acute kidney injury. Now, not every acute kidney injury is the same in terms of the severity, and in the past 20 years, we've done a grading system, mild, moderate, and severe, and we typically say AKI stage 1, 2, or 3. But if you, roughly, if you think of it, half of those are severe. Half of those 30 to 35 or 30 to 40%, depending on where you see, are severe enough to 10 to 15% of those need dialysis. Of course, some patients are more predisposed to dialysis. If you're already on the mechanical ventilator, more than 10 to 15% end up on dialysis. So, of course, it was very difficult in terms of overwhelming, the hospitals and the capacity to provide dialysis, whether it's through equipment or even nursing shortages to provide the care, and even physicians. I mean, I said I'm caring for, if I care usually to 15 to 20 patients, now it almost doubles the number of patients we're seeing. So, and many of those patients are going to end up discharged with AKI. So among those who end up on dialysis, half of them are still on dialysis on discharge.
Wow.
So if you think it's going to overwhelm also over time, it may not be felt yet, but over time you can see the dialysis units will feel that impact. And the reason I'm saying not yet, because if you remember at the beginning, many hospitals emptied their surgeries, regular surgeries and cardiothoracic surgeries so that they can accommodate COVID. And these surgeries typically themselves are associated with AKI, but over time it will be net positive on the dialysis unit. There are many things we do differently, or at least we might approach a patient with AKI in a different way, or especially in the cases of a surge when your hospital is overwhelmed. Some of the things we do when possible, we localize patients with COVID into adjacent rooms when possible, so that one dialysis nurse, if you're providing, of course, acute HD, so that one dialysis nurse can simultaneously deliver to 2 patients or more than 1 patient. And then if possible, we dialyze the patient, and if we have the resources in the room, so that we are not transporting the patients in the hospital to the dialysis unit and potentially expose other patients. Many of these patients are very hypercatabolic, the ones in the ICU as well, meaning their BUN and their creatinine is always, high because they're catabolic. And many of them are unstable when they have ARDS. They'll be on positive pressure ventilation and their blood pressure would be on the lower side. So many of those are on CRRT or continuous renal replacement therapy.
Right.
And your CRRT capacity or ability to deliver CRRT, if you have many ICU patients, many from the beginning in Italy and France and even us was overwhelmed at one point. You use all your CRRT machines, so you have to come at times with creative ways to deliver dialysis to the patients if you're overwhelmed. So one of the things we did and other institutions is you deliver the CRRT, you use the CRRT machine, but you increase the dialysate flow rate. So meaning you make it more efficient, but you deliver it over shorter time so that machine you can take and dialyze another patient.
Okay.
Some institutions, we didn't do that. They were so overwhelmed that they also resorted to peritoneal dialysis. Of course, using peritoneal dialysis comes with its own challenges, especially if you don't have a built infrastructure for it. You cannot not be doing peritoneal dialysis for acute kidney injury, and you don't have a mechanism in the hospital, and all of a sudden say that you're going to provide peritoneal dialysis. But if you have the infrastructure, that has been done. But in the ICU, just things to remember, in the ICU, it's very difficult to do PD on patients with acute respiratory distress syndrome. Okay, their lungs are inflated, and if you put anything in their belly in terms of fluid, it's going to push on the diaphragm and compromise the oxygenation. Although it's been done, but it's not ideal, at least in ICU patients. However, in many patients, it's very, it's doable, especially if they have, AKI, they're on the floor. It could be done.
Okay.
If it's done, go ahead.
Okay, I'm sorry. I had one question. I just wanted to make sure we get in. This is good. And then I'm going to switch back to Rosheen. So one question comes in: does the anticoagulation choice and regime change while doing renal replacement therapy and AKI, is that as a consequence of COVID? Do you understand that question? I'm not sure. So in terms of your anticoagulation choice, and the regime change while doing renal replacement therapy and AKI, is that a consequence of COVID? Which choice, does COVID kind of?
Yes.
How does that play into what anticoagulation you use for that renal replacement therapy?
Assuming, Ms. Pryor, the question is for me.
Yes, sir.
Yes. So circuit or dialysis circuit, whether it's the CRRT or even hemodialysis circuit, is susceptible to thrombosis in patients with COVID. They are hypercoagulable. So even when you use heparin, they might clot frequently. And there is varying reports. So at minimum, you should always try to use anticoagulation, whether it's unfractionated heparin or in the case of continuous renal replacement therapy, you use citrate anticoagulation in many institutions. Some institutions use heparin, some institutions use citrate, and some institutions before COVID use none. If you're not using anything, you're predisposed to a lot of clots. You should use either heparin or citrate. Some institutions have used heparin and citrate together. Although there are reports that may be anecdotal reports that heparin is better than citrate anticoagulation in the case of CRRT, we haven't seen that. In fact, in our institution, citrate was much better than heparin. But you have to anticoagulate these patients if there is no contraindications, of course. Right. This is an important question because in general, many institutions, including us, if you are seeing a patient with AKI in the hospital, non-COVID patients, we don't anticoagulate because it's a 3 to 4 hour run in the hospital. And many of the patients can be, surgical patients. So we try not to anticoagulate in the event that the patient can develop a bleed. With COVID patients, we try to anticoagulate almost all of them, and unless there is a real contraindication because of their hypercoagulability.
Okay. All right. Thank you. I'm going to switch just a little bit to Mr. Rosheen. Now, I'm going to ask just in reference to your journey. Did it start as a acute kidney injury, or how did yours start? And then I have a question for you as we go. Or did they was it full-fledged? Just everything was kind of you're considered chronic, and we have to just start you. Okay.
Yeah, it was actually came out of nowhere. I went to see my primary care physician, and he's like, as of today, you are retired. He's pretty much said that like any man, we put our health on the back burner. It'll take a limb fall off before we go to the emergency room. So he was like, as of today, you can't put your health on the back burner. You got to start dialysis, which shook me. But, after educating myself, going on, looking at the videos about dialysis, my grandmother was on dialysis. I just did my research to get myself more comfortable with the experience and seeing what I needed to do. But it was a survival moment. You know, you got to do what you have to do.
Right, right. So you started on hemodialysis, and
Yes.
and you eventually were able to do peritoneal dialysis. Or
Yes. That's
okay. So tell me,
six.
go ahead. Tell me a little bit about that.
Well, when I started out, it was pretty much the surgeon who put in my fistula at the time. We were sitting there just having a good conversation, and he just stopped me, and he's like, you know what? I think everyone should have a backup plan. He said, I'm not only going to put in your fistula, but I'm also going to put in your PD catheter. I don't know if he was a psychic, but after 6.5 months of me doing in-center and experiencing that, I caught a clot, and which they couldn't repair in the fistula, which was the opening the door, the introduction to peritoneal for me.
Wow, wow. And so that worked for you for a while. I have a question, and from Angie. Other than swimming opportunities that you mentioned and other benefits, which home modality provided you more benefit and gave you kind of your life back?
Well, to be honest, from my experience, it was home hemo.
It was. Okay.
And the reason is because basically it worked for me rather than the other way around. It was on my schedule rather than me being on its schedule. I did 5 days a week, 3 hours, any time in the day that I choose. So I never missed an engagement. I never missed an appointment. And the way you feel afterwards, disconnecting from that machine, I'm lacing shoes, I'm heading out. You feel amazing. And especially having that control to do as you wish. Nice.
All right. Well, I had one other question. In terms of your nursing, I know this is our nursing tract. Can you tell us a little bit about how our nurses were involved in your experience?
From the beginning, outstanding. I truly thank my nurses and my techs. They were so patient and so thorough and so encouraging. Without them, I wouldn't have been confident. I wouldn't have been assured to be independent as I was without their help and encouragement.
Wow.
So I commend all the nurses out there. You are a big part of patient success.
Thank you. And so I have one more question. We're coming down. We're about maybe 5 or 6 minutes out. And I was just gonna go back to Dr. Yessayan for a minute. And you mentioned you were able, or you had the opportunity to start some of your patients with peritoneal dialysis, although that wasn't optimal, correct? For acute kidney injury, that CRRT is probably the optimal. I'm sorry, go ahead.
Yes. No, we didn't do any peritoneal dialysis.
Okay.
The reason, is we had enough resources in our institution.
Okay.
And the second option was after CRRT, we used the 10-hour treatment, but with the per hour higher efficiency. And then we used our hemodialysis resources. And I think, I think peritoneal dialysis can be challenging in the ICU for ARDS patients. So that was one of the reasons we didn't do it, but it could be done.
Okay. All right. Rosheen, I have another question come in for you. When you were doing peritoneal dialysis, can you swim? Were you swimming with the peritoneal dialysis? Was that something that you were allowed to do, or they told you it was okay, or?
Yes, actually, you could swim as long as it's salt water because it's able to cleanse as well. So I would take my trips to the ocean. I would go to a lot to Miami, a lot of Florida trips just to get that benefit of that beautiful water, and it has to be salt. Right. So when I went to home hemo, I can get back into the chlorine pools and the jacuzzis, which was an upgrade. Still like the ocean though. Still love the ocean.
Yeah. All right. All right. Well, I had one more question, just for Rosheen. Your story is just amazing. And I guess my question is, we talked a little bit about when that education would take place. How, I don't know, what words of wisdom can you just give to our audience on the caregiver side, the health caregiver side, just in terms of approaching persons with chronic kidney disease, and just kind of pulling them through. You were on the LVAC, you went to hemo, you had your access, from what I heard just now, clotted on you. What would be the best way for you to tell us how we can kind of keep you motivated? Because I'm sure some of that time you were like, oh my gosh, what is next?
Yeah. What I can tell you is just when, a patient, the number one thing is they don't want to hear that they're ill like this. Mm-hmm. So it starts with the education, as well as comforting, letting them know you're not in this alone.
Okay.
And you have someone with you that's going to be there for you step by step. And as long as, as a healthcare individual, you just want to comfort them and let them know they're not alone, and that the particular steps they're going to go through, the journey that they're going to go through, has an opportunity of being very successful. For me, when I started dialysis, I had to make a choice. It's not going to, if it was way back in the 40s, we wouldn't have a chance. But now the technology is up, we have an opportunity to continue to live until we get that gift of life. So if you're a caregiver, you just want to be encouraging. You want to be able to provide an education to them to make it simple and understanding about the process. And as long as that comfort is there, and as long as that encouraging of faith, they can succeed. As I did.
That's what makes the difference. Thank you. Thank you so
Indeed.
much. So the one follow-up question for you, and then I have one, I'd like to let Dr. Yessayan give some closing remarks. What was your greatest challenge while you were on home hemodialysis?
One of my greatest challenges was the cannulation part. That's always been my Michael Myers, my Freddy Krueger. I've always been afraid of needles, but the time it took me to really educate the point of how long it hurts, and to understand it's about ouch. As soon as you get to that chub part, that needle's in, and you're good to go. So I had to just basically look at them, take the needles out, put those needles in. And once I got familiar with that, and being that my nurses were so thorough, educating me each point from the process, I began to feel more comfortable. And once that occurred, it was sky's the limit. I never want anyone to cannulate me again. Right.
Nice. That's an important part. And it is a hurdle sometimes that we have to help each other, and you guys get over when you're doing that home hemo, but certainly worth it. Certainly worth it. So Dr. Yessayan, I'm gonna just pose to you one last question, just in terms of acute kidney injury in the renal replacement therapy. And you mentioned, I want to say, what did you say? Maybe 10 to 12% will still need, I guess, go into chronic therapy. And how did you find, in terms of educating your patients, how did you find, do you have to follow them up with that? Okay, this is, we thought this was going to be a short-term thing, but it's looking like it may be longer term. How do you?
It's, well, first of all, I think I read a recent survey done in the population, asking them whether there is some level of understanding the risks of COVID causing AKI. The percentage of people everyone associates COVID with, lung problems, right? But the percentage of patients who are ending up on dialysis are a lot. So there is lack of knowledge about this problem with COVID. So that's one. Second, it's also very difficult even communicating with the patients their kidney situation. Most of the patients we see who have AKI are already in the ICU on the ventilator, so you are discussing this with their family members who cannot be in the room to begin with.
Right.
I mean, I have some very difficult experiences the first month or two of COVID with younger patients. Not that ages, but some of them stay with you, the torment. But I can tell you right now, I think overall we're seeing better outcomes in general, and we are on the right track. There is no, solid evidence, but the emerging data is showing that we are, doing much better than before.
Great. Thank you. All right. Well, this has been a great session. I'm getting little, not nasty grams, but I would love to stay on and continue the conversation, but our time is ending up right now. And we also have a video that's going to play. I want to thank you so much, Dr. Yessayan and Rosheen, for taking some time. Thank you for your stories, and thank you for your explanations and your presentations. We've all learned a lot through this, and we appreciate you. I hope everyone has a wonderful rest of the conference. I think this is going to be ending the nurse tract of that, but we look forward to seeing you next year, and I think we'll have a video following this. Thank you so much. Thank you, guys. Stay warm.
I hope you have enjoyed the past couple of days of the conference and benefited from the
Thank
new
you, guys.
library. We encourage you to
Bye-bye.
participate in the last day of the general nephrology track that begins with the breakfast networking event tomorrow. We also encourage you to participate in the poster session. We would like to thank all of you who submitted abstracts for this program. We appreciate you all for your time, attention, and participation in making this conference a priority. We hope that this forum accomplishes our mission to advance nephrology nursing practices and positively influence outcomes in response to growing quality issues. As an added benefit, do not forget the poster sessions, industry symposiums, including the chat feature, will remain available until August 1st, 2021. We also hope that we were able to provide you with the opportunity to develop online interactions that foster long-term relationships and potential collaborations with industry thought leaders, medical professionals, researchers, and scholars. We look forward to welcoming you again next year in 2022 at the Renal Research Institute 24th International Conference on Dialysis, Advances in Kidney Disease. Thank you again, and see you in 2022.